Good morning, and thank you for listening to my virtual poster presentation titled Underutilization of Statins in Adults with HIV, the Treatment Gap and Predictors of Statins Initiation. Studies have consistently demonstrated an increased risk of cardiovascular disease among people with HIV compared to the general population. And statins are a class of medications that reduce LDL cholesterol and have been demonstrated to reduce CVD risk. Despite the potential benefit of statins for people with HIV, studies have shown that they are less likely to receive statins as compared to adults in the general population. However, the reasons why this occurs remain unknown. In 2013, the American College of Cardiology and the American Heart Association released new clinical guidelines, broadening the criteria for statin eligibility as compared to previous guidelines. Thus, there is a statins treatment gap among those eligible for statins and those initiating statins, which may be exacerbated by this change in guidelines. Therefore, we sought to characterize the statins treatment gap among people with HIV in the US from 2001 through 2017, as well as to identify predictors of statins initiation under these new guidelines. Our source population for this analysis was adults participating in the NA Accord. Individuals who were 18 and older were included if they had covariate data available and were under observation during our timeframe of interest. To characterize the statins treatment gap, we estimated the proportion eligible for statins, and among those eligible, the proportion initiating statins annually. Statin eligibility was a time-updated variable defined using treatment guidelines applicable to each timeframe. So ATP3 guidelines from 2001 through 2013, and the ACC-AHA guidelines in 2014 through 2017. To identify potential predictors of statin initiation under these new guidelines, we used Poisson regression with robust variance to estimate adjusted prevalence ratios with 95% confidence intervals. There were 16,409 individuals who met our inclusion criteria, among whom 7,386 became eligible for statins during our time period of interest. This figure depicts the annual proportion of those eligible for statins and those receiving statins among those eligible. The statins treatment gap, those who were eligible for statins but did not initiate statins, is represented by the dotted blue area. In 2001 through 2013, the proportion of individuals eligible for statins was stable, ranging from 22 to 26%. And statins initiation improved markedly over this time period. In 2001, only 13% had initiated statins. By 2013, 45% among those eligible had initiated statins. In 2014 through 2017, under the new ACC-AHA guidelines, there's a notable increase in those eligible for statins, ranging from 51 to 54%, averaging at 52%. Statin initiation, however, in this time frame was relatively low, ranging from 25 to 32% during this time period. And here are the results of our analysis on the predictors of statins initiation following the 2013 ACC-AHA guidelines. There were 3,263 individuals who became eligible during this timeframe, 590 of which initiated statins. Age was associated with an increased likelihood of initiating statins. Interestingly, as compared to never having HIV treatment, use of a protease inhibitor was inversely associated with statins initiation. In our nationally representative sample of people with HIV, there is a statins treatment gap, such that less than half of those eligible for statins are ultimately prescribed them. This statins treatment gap was compounded by the change in guidelines, which broadened statins eligibility criteria. Our inverse association between protease inhibitor use and statin initiation from 2014 through 2017 may be related to clinician concern over drug-drug interactions or possibly confounding by indication. Given the increased risk of CVD among people with HIV, improving uptake is critical. Additionally, further research is needed to clarify predictors of statin initiation with longer durations of follow-up and observation following the guideline implementation in 2013. There are several people that I'd like to thank. First and foremost, the participants of the NA Accord, as well as the investigators and study staff of the NA Accord and Amy Freeman, who is critical to the successful completion of this work. I'd like to thank my advisors, Dr. Carrie Altoff and Brian Lau, as well as my dissertation committee members, Dr. Kala Viswanathan and Todd Brown. Lastly, I'd like to acknowledge my funding source, which is a F31 through the National Cancer Institute. Thank you for listening.